My name is Sam Saha. I am a general internist at the Portland VA Medical Center and the Oregon Health and Science University, and I also serve as chairman of the Oregon Health Services Commission. I recently published a paper on the use of comparative effectiveness research in the New England Journal of Medicine. Comparative effectiveness research is a very simple but powerful concept. It is in a nutshell comparing one product to another in medical care to see which is the best and which offers the best value. It's essentially a consumer reports for medical care. It gives you that kind of information on which treatments have the best effectiveness, the lowest side effect profile, and in some cases which offer the best value for the money. And so it's essentially, a way of allowing for comparison shopping in medical care. One thing that, if you've ever seen Consumer Reports, they compare different products, say cars or appliances, and they allow you to look at which ones have certain features and which ones seem to be the highest quality. And they also give you information on the cost and tell you which ones are the quote-unquote best buys. And in some countries, they use comparative effectiveness in the same way. They tell you basically they give quality ratings to different medical care services, and they tell you the cost, and they tell you which ones they think are the best buy. In the United States, we have taken a much more cautious approach to comparative effectiveness research in that in our current proposals in the healthcare reform bills, for instance, there are stipulations that comparative effectiveness research will look at different medical care services and products based on their quality, but will not talk about cost. So basically the way that we get medical care these days is that the patient pays for insurance that then in turn pays for the care that they get. Once the patient pays their premium for their insurance policy, they have very little incentive to really shop on value, and the doctor has very little incentive, at least financially, to offer good value. In fact, the doctor is paid more for spending more. The problem with that system is that the people who are making the decisions really have no incentive to control the cost of care. Comparative effectiveness research can help to control the cost of care, but only if there are significant incentives for doctors and patients to choose the most effective and highest value options.